Hi, good morning. My name is Dr. Rajadnan Ahmed, and I am a psychiatrist. I work in UK. And this morning I have Dr. Muhammad Saad Asghar with me. And this is a career guidance interview for doctors who are interested in training in ophthalmology. Dr. Asghar is IMG, who is originally from Pakistan and did his graduation in 2018 from UAE, and then he came to UK in 2020, and he has now started his ophthalmology ST1 training. And ophthalmology is one of those specialties when people, um, IMG especially, they get confused. And is it something that they should go for? Is this too competitive? Is it something that they will enjoy? Is that something that they will actually get? So I thought it would be a good idea to ask Saad some of these questions and ask his experience of how he got into ophthalmology, and so far, how is he finding that? So thank you very much, Saad, for joining this and helping the IMGs.
And it's my pleasure to be here and help guide the IMGs towards the specialty of ophthalmology. Yeah.
So first question, if you don't mind, if you can take us through your journey as a doctor so far. So starting from your medical school, what have you done so far?
Right. So I'm an IMG of United Arab Emirates. I graduated from there in 2018. And since then, what I did was I did 1 year of internship there itself in UAE, the F1 equivalent that we do. And during that time, I was also doing my internship. I was studying for PLAB 1. And during the internship, I gave the PLAB 1 and passed that one. After internship finished, I then started preparing for PLAB 2. And I was not working in any clinical capacity after my internship. I was just studying for PLAB 2. And then once I had booked my PLAB 2, I then went to the UK to do 1 month of clinical attachment. But that clinical attachment was not in ophthalmology. It was about 2 weeks in acute medicine and one week in stroke medicine. I did that, and that's after that, about 6th of Jan or January of 2020, I received my GMC registration. Right? And right after that, I started applying for the jobs to the UK. So then most of the first half of 2020 was just applications to different jobs, and I got only two interviews out of maybe 100 or 200 of um, job applications. And the first one was not successful for me in geriatric medicine, but the second interview was in stroke medicine, and it was in the same hospital in which I had done the attachment, which was my stroke medicine attachment. And so that was the job that I first started off with in the UK, and that started in about, I think, August of 2020 is when I started that job. And so since then, since 2020 of since the stroke medicine job in 2020. That was my main job up till now, this year when I entered into training. I did not change to any other jobs. It was the same job which I worked in about 2.5 years in the stroke unit. Um, and I was building my CV towards ophthalmology all during this time. So because what I did was I got in touch with the opthal unit locally in our hospital. So I made links there. I spoke to people there. I didn't want to lose all those contacts just by changing the hospitals or changing the jobs. And so I then stuck to that job, prepared my application, prepared my portfolio, and in 2023, this year, started my ST1 training in ophthalmology.
That's great. That's a very good. And I think you've done so well so far. For to enter the ophthalmology ST1, so first I need to ask you: is there any other levels you can enter as ophthalmology, or is it only ST1 you can only
That's a,
enter?
that's a great question because there has only been a change to this recently. Up until last year, up until the year or you can say this intake, this current ST1 intake of 2023, there was also the option to enter into ST3 and do your training up until the end of the training. But this year was the last time that was going to happen. From next year's recruitment, it's only going to be ST1. They have removed the option to
Hmm.
enter the training through the ST3 route. And so that will be the only option for anybody wanting to enter into training.
Okay. And we know for all ST1 level jobs, you need a CREST form, which is the foundation competencies. If you haven't done foundation year years in UK or have done
Yeah.
FY2 standalone. So
Yeah.
that requirement we are aware of. What were the other requirements to become eligible to apply for the training in ophthalmology?
All right. So I think as you said, one important requirement is the CREST form. The other important requirement is the sort of you cannot be overqualified to enter into ST1 training. So one CREST form is a definite requirement to be able to enter specialty training, just like other specialties. Up until this current intake, in which I have taken the start into ophthalmology training, you must not have had been overqualified to enter into ophthalmology, which means that, let's say you had been working in your country, in your previous country, for 3 years as an ophthalmologist, you will not be eligible to apply to ST1. You must have 18 months or less experience working in ophthalmology to be entering into ST1. Now, because they have abolished, for everybody else who had more experience, you could enter at ST3 level, right? But now that they have abolished the ST3 entry, they have instead increased the sort of months that you could have worked in ophthalmology before you came into ST1. And so that has now become 30 months, 30. So now if you have worked 30 months or less in ophthalmology, let's say back in your country, maybe as a junior clinical fellow job here in the UK in ophthalmology, you can still apply for ST1. That's another important consideration to think about, because many people will be wondering if they were already specialized in their countries, and
Mm.
maybe they have been practicing for years now back home, it will be quite hard for them to get into ST1 training. They could instead maybe try for associate specialist jobs and then work towards Caesar route rather.
Okay. Um, and uh, so these were the basic requirements, I think, which will make you eligible to apply and put an application. So what was the recruitment process like? If you take us through that, because did it involve any exams? Did it involve any interviews? Did it involve any portfolio, any markings and all that?
That's correct. It's a what I really like about from the beginning. What I really liked about the ophthalmology recruitment pathway was a lot of it is very objective, which means that a lot of it is not left up to imagination. You do have fixed criteria and guidance which you can work towards. So I will start by talking it about in the manner of looking at it in as a 100% score. So your portfolio or your final score, based on which you are ranked against everybody else in the country, is made up of 100 points, right? Out of these 100 points, 50 points that you get in your portfolio is from your portfolio, which includes things like research, things like commitment to specialty, things like teaching, education. I will come to that about how you can build each later on, but 50%, 50 points are contributed from your portfolio, right? What about the rest of the 50? So the rest of the 50, 30 points out of the rest of the 50 is contributed from your face-to-face interview. That is 30. So now we have taken care of 80% of your score, right? What's left is 20 points now. 20 points is made by the MSRA exam. And now you have the 100 total points. Once you collate all these points from all these various sources together, the score you get is ranked against everybody else in the country to give you the rank based on which you get the job. The
So the
recruitment, sorry, go on.
Sorry, the first part would be the MSR exam. That's what I was going to check because once you
Exactly.
submit the application, the first step would be obviously you're making your CV. That can take a few years in submitting all
Exactly.
that. But the first point would be MSRA. Is that right?
That's absolutely correct. So when the application window starts around November time in
Mm.
the year, and you submit your application with your CREST form, that is the first point in which you submit your CREST form. Nothing else. You're just submitting your CREST form and stating, I'm interested in ophthalmology. You give your past experience. That's it. After a month or so, you receive an invitation, as you said, for the MSRA exam, right? That is usually held in Jan to Feb.
Yeah.
So at that time, you're just preparing for MSRA. You're not preparing for anything else. You're not preparing for interview or anything else, just the MSRA. Right? Once you take the MSRA, the thing with the MSRA exam is every specialty has its own cutoff and numbers it requires from, even
Yeah.
though the exam is the same. So ophthalmology historically has quite a high benchmark that it sets for its candidates, because if you don't cross the MSRA threshold that is set, that is the end of the line for you for that year. You will then have to apply next year if you haven't crossed the benchmark. because the applications are so many every year. So if I quote the last year's number, about 700 applicants initially applied to 78 jobs. The competition ratio is about 8.97 last year. Right? They must need a way to filter this then. And that was then the MSRA exam,
mm,
where the cutoff is usually so high that a lot of the people are just filtered at that point itself. And so I would really focus on the MSRA exam and not underestimate it at all, just because of how competitive it can be. Right. So MSRA exam is done in Jan to Feb. Let's say you've cleared that, you've cleared the benchmark. Your score then, whatever score you got in the MSRA, will be compared to everybody else in ophthalmology who also crossed the threshold for the MSRA exam. And then your score will be converted into a score out of 20. Because if you remember, I said 20 points is what contributes
mm,
MSRA exam. So let's say even if you crossed, if you barely crossed the MSRA threshold and crossed out of 20, you might get 1, 2, or 3 points, right?
mm,
So it's still you need to score quite well to get good points in the final outcome in the MSRA. So now that your MSR exam is done, the next point in the application system is you submitting your portfolio as a PDF or as a PowerPoint to the sort of the application committee. They will ask you to upload all your
mm,
evidences of presentations, evidences of research, evidence of exams done together in a nice, well-made PDF. You submitted them online, and this is before the interview has happened. You've just uploaded it on one of the days. Then the interview happens after a few months. I
mm,
believe it was April this year. I'm not really sure, but after a couple of months from MSRA, the interview then happens. The interview is completely online, face to face, with the patient who will be sitting on the other side of the screen. What will happen is there will be consultants who will be on the side as well in the Zoom meeting, but you can't see them. You won't be able to see who's
mm,
examining you, but you can see that their names are there on the side. And then you will have this face-to-face patient consultation. That's what it is. It's not a communication scenario like a separate dedicated, or it's not an audit scenario, a research scenario.
mm.
It is just patient consultation scenario. It can be a communication scenario in the same at the same time. It can be breaking bad news, whatever, but it will just be a patient consultation. That's it. And this patient consultation contributes 30 out of the total
Mm.
100 marks. It's pretty significant mark as well. Right after they release the interview score, a few weeks later, they will also tell you that during this time they have checked the portfolio and they have found that this is what your portfolio scores as well. And so now, after the interview stage, they have everything they need to finally decide what is your final mark out of 100.
So
That's
this
basically the process. Yeah.
patient, I think this is a very good rundown of how the marks are scored in ophthalmology. This patient interaction you just mentioned, would they give you some idea what the patient would be about? Because it's like, for example, in psychiatry we have like a little interview, but they give us the questions in advance that this is the question, this is the scenario we're going to ask you. I'm not sure if in ophthalmology they tell you in advance, or it's like a surprise, or every person is getting the same scenario, or every person they're different stations. I just wanted to check that.
Yeah, that's a great question. What is basically done is most of the senior trainees or the people who have already got into training, they remember the sort of questions that they got and the scenarios that they got, and we are mostly using those their experience to prepare for this interview. There is no real guidance about what kind of patient that you can be presented with. But generally, these are communication problems I've noticed. So, for example, the cataract operation is cancelled, so um, you will need to counsel the patient about
Mm,
the fact that it's cancelled. There could be the fact that a patient, um, again, another cause of cataract patient being cancelled is maybe the blood pressure was too high,
mm,
and you need to just tell them about the risks that we are looking at here. Another could be breaking bad news. You've diagnosed them with a blinding illness, and you're just trying to counsel them. Giant cell arteritis, another one,
mm.
um, where you're trying to counsel them, or that this can cause blindness, so we would like this to be treated, but they don't want to get treated immediately. So it's mostly these kind of scenarios, but they don't give you any sort of questions beforehand that this is the case that you're going to have. It's just general ophthalmology and anything you can expect. At the level of a foundation doctors, like when they near their
Mm.
journey, what kind of scenarios you can encounter in the department. That's what it is about. Yeah,
Mm. I think the important part is you said the 50% of the marks are from the portfolio. And I
that's
just
correct.
wanted to, I think that will be good for you to explain some of the things you have done and some of the things IMGs can do, because this is something that you don't actually need to apply for uh, ophthalmology first and then start making portfolio. I think we start making up a portfolio as soon as we graduate, or even when we are medical students. So if you just give us
Absolutely.
some idea of what does that involve.
Yes, absolutely. Yes. I think you're absolutely right about the fact that it's 50% of the mark, right? So the more you can score in this section, the better off you will be when the actually time comes. Because again, I think in this whole process, one of the most objective, the very objective part of this whole application is the portfolio. There is no subjectivity to it.
Mm.
You either have it or you don't. So you can really score well in that, work towards that. Interview, sometimes people can have different scores even though they did the same thing. But that's because we are being examined by other humans as well. So let me go through the portfolio then. The portfolio guidance, first of all, I would like to leave a sort of like a link in the description as well for the
Yeah.
evidence folder, which is publicly available. Anybody can access that, and this will give guidance to start from university as well, as you said, which is a great idea. Just for myself though, personally, I wasn't really aware of this evidence folder when I was in university, so I wasn't really in a position to actually work towards these things. For me, I haven't really done much ophthalmology before I even came to the UK and started working on my
Mm.
portfolio in my separate time. So for anybody who doesn't have any experience at all, I think I would be an example for that. Is that I only started working on my portfolio once I came to the UK in 2020 when I started my stroke job here. That is when I actually started working in my free time on my portfolio. Before that, I have had no ophthalmology jobs. I have had no ophthalmology contacts. All I had was a university rotation based on which I developed the interest, and that was it. So the portfolio is broken down into different sections. The first section is a list of previous posts in which you mention what other previous posts have you held. Doesn't score any points. This section, I think, is just there to just make the committee aware that what sort of experience you've had in ophthalmology before. So for me, it was just my stroke job here, nothing else. The next point is qualifications with certificates or letter of proof. Now, in this section, again, it's a bit hard. During this whole portfolio, I will talk about some sections as being high yield, and I will talk about other sections as being low yield. I mean, if you have them, well and good. If you don't have them, it's not that big of a deal, right? So I would call qualifications with certificates of letters or letter of proof as being a low yield section, because the sort of things that you get gain you points in this section are things like PhD or sort of like MD thesis or MSc or BSc. Many people don't have them, right? I didn't have them. I didn't have anything among this section. So no, I have no PhDs, I have no MD thesis, I have no masters in science or um, bachelor's in science. But if you have degrees separate from your university, so no intercalated degrees, no intercalated degrees are considered in this, only outside degrees. So maybe you've done a PhD in a subject, maybe you've
Mm.
an optometry degree, and now you're coming to ophthalmology. All those help. All those give you points here. Right? MRCP, MRCS don't give you any points in ophthalmology at all.
Mm.
No other exams will give you any benefit here, right? So 4 points from this section are contributed, right? Out of the 50 that we talk about. Next, you have prizes, awards section. In this section, if you've had any, again, I would consider this to be a low yield section because again, not everybody has prizes, not everybody has awards. I didn't have anything in this section at all. This section also was empty for me. But if you have any best presentations or posters presented at a conference, uh, if you got the first place in the FRC of Part 1 exam, which is a notoriously difficult exam, and if you got the first in the whole country, you'd get 2 points for that. There's a Duke Elder exam which you can give in your undergraduate study if you got a prize in that,
mm,
if you came in the top 10% of that exam, if you came in the top 60%, you can have points accordingly for that exam. So if in your undergraduate, that is something you could work on, is the Duke Elder exam here in the UK. And that can score you points in this section as well. Then is what I call a high yield section, which is ophthalmology specialty lengths
mm,
and commitment. This section, I've maxed it out. It gives you 12 points total, and most people, given enough time, should be able to develop 12 out of 12 points from this section, right? It includes anything that especially is related to ophthalmology and shows that you're committed to that specialty. Two of these are exams. So the FRC of Part 1, which is the Fellow of Royal College of Ophthalmology Part 1 exam, just like MRCP Part 1, there is FRC of the Part 1. If you get that exam done before you actually enter into training, you're going to get 3 points. These are quite a lot of points.
yeah.
And you also have to remember that this is an exam, anyways, you're going to give, you have to give in your specialty before your second year of training. So might as well get done with it before if you can. The first 2 years will then be straightforward. So I have done this exam myself. Then you have Refraction Certificate, which is a certificate which teaches you how to prescribe glasses and how to be a good refractor. It's difficult to get it done before entering into training because you need access to the equipment which is used for refraction. And so many people don't. I don't have this exam, right? But if you're working as a junior clinical fellow in ophthalmology beforehand, you will have access to this and you can get this exam done as well, which gives you 2 points. That is also one way. Next, you have non-peer-reviewed publications and case reports in ophthalmology that you have published,
Mm,
because peer-reviewed is a separate section in this portfolio. This is non-peer-reviewed publications that you have done. That gives you a few points. If you have done any ophthalmologic electives or any undergraduate project, that gives you 1 point for that. So in undergraduate university, you can join your ophthalmology department, do any project with them, do any sort of elective with them, and that'll give you points for that, right? So I have done electives in my year. So in ophthalmology in my university, I spent 1 month during my foundation F1 year as an elective block, and
mm,
that gave me points here as well. So you can do that during your university years. That's where you can start. Taster week, when you come to the UK, you can take 1 week off from your job and just spend that time in the ophthalmology unit, get a letter for that. That gives you another point as a taster week. Next thing is attending the ophthalmology clinics and theater sessions in your free time. So whatever job you're doing in the UK, if you just speak with your local department, you go on to them, you tell them that I just want to come, whenever I get free time, I just want to come and sit here in the casualty and theater sessions and have a paper signed off for 10 sessions for this casualty and theater. You will use that as evidence and put it in your portfolio, and that will give you a point as well here. Then there's a simulation machines that are present throughout the UK. Surgical simulation machine called IC. If you spend 4 hours on that machine at various points in time and you collate the report 4 hours long, you
mm,
can put that in here and that gives you a point that you've spent time on the surgical simulator for 4 hours. There is a course, Introduction to Microsurgical course, which anybody can take in the UK as a doctor. That gives you point as well. It teaches you how to do microsurgical suturing and incisions into the eye. That gives you point as well. Meetings that you have attended, if you've attended international meetings or conferences like Royal RC Oft conference or Beavers conference, that gives you points. National conferences, which are not international, but they're still national level, gives you points. Regional meetings gives you points as well. All of these things are included in the commitment to specialty. This is a section which I feel you can score maximum in given enough time, and this in control of everybody as I have mentioned. So that is commitment to specialty. Next section is the multi-source feedback section. Right?
mm,
Again, everybody should have access to this. In the UK, you just have to get feedback from your colleagues, and this gives you maximum of 4 points,
mm,
depending on how good your feedback was. So let's say if your feedback was great score with many good comments, with positive comments, that's you score max 4 points. If it's appropriate good comments but not so many, that's 3 points. If it's limited good points, 2 points. So it's based on that. So
Mm.
what you're aiming for is great comments, great praises in your MSF based on how you were in the department,
Yeah.
right? And that will give you 4 out of 4. That's MSF. I scored full in this one as well. So now we go to the publication section. Publication section, again, I would call this a low yield section because the publication criteria is quite strict.
Mm.
It has to be, you can only score well in the section if you were the first author or you were the joint first author, right? And that gives you 3 points in this section. For any other publications up to the being the fourth author, you get only 1 point. Even if it's published, well, biggest journal, best journal, if you are not the first author, you will
Mm.
get 1 point only, right? That has what's changed since last year, because since last year was a different criteria and it was more dependent on how impactful your study was. So what people were doing was they were maybe the 10th author or the 11th author, and
Yeah.
they were just piggybacking onto somebody else's study and getting like great points. So the committee probably realized that, and then they scored much higher now for people who have actually are the first author. They get a lot of good points, even if it's a small study. But if you're the first author, it gives you great points, right? So that's the publication sections. I personally had no publication, so that should again be sort of encouraging for those people who don't have a lot of publication history. I myself had no publications, and so I focused on all the other sections in which I could score well.
Mm.
Great. So the next section is quality improvement and audit projects. In this section, you can score a maximum of 5 points. I scored the max in this section as well. What you can do is, I would recommend working on this project if you are in the UK. It's much easier and the systems are well established to be able to do audits and to be able to bring up change. And that's what I've done only after I started. I came here, I did it in my
Is
stroke
that an
job.
audit in ophthalmology, or it could be anything? Any?
That's a great question. It can be in anything. That's unlike publications.
Yeah.
Audits can be in anything. So I did my audit in CT angiogram in stroke. That
Oh.
was my topic. And what gives you point in this section is rather the impact of that audit, not the subject. So for
Mm.
example, if you want to get the 5 out of 5 points, you have to have sort of change that you have implemented supra-regionally, right? So your audit not only brought about change within your hospital, but it also brought about change in the region as well, right? That gives you an idea about how is the audit scored. Along with that, the audit should be having a closed loop. You should have done it again. You should have implemented change. You should have been involved in the initiation, design, and writing of the audit itself as well. So very nice criteria mentioned in the specific evidence folder that I've linked to.
Mm.
Just follow that to the T, and you will get full marks in this
Mm.
as well. Next section, presentations. Now, in presentations, you can score maximum 6 points. Again, I call this a high yield section as well. I have scored max in this as well.
Mm.
Depending on what sort of presentation you've done, you get marks accordingly. If you've done an international presentation, that scores more than a national presentation. Both score, right?
Mm.
If you've done an oral presentation over a sort of poster presentation, that gives you more points, depending on which one. So I've done international oral, I've done local poster, and so that's how you can max out
Mm.
points in this section. It can be an audit presentation, it can be a case presentation. Does not matter what is the subject. What matters is it's international, it's
Mm.
oral, is it regional, is it national? That's what matters the most.
Okay.
Yeah. I think one good point worth repeating is that you cannot repeat the evidences throughout this portfolio.
Yeah.
So, for example, if I'm presenting something up in the audit section and I'm saying, oh, I presented this audit in a national meeting and this is my evidence, I cannot put that same evidence down there again in the
Mm.
presentation sections. I have to have separate evidences for separate things, right? Then you have the education and teaching section. Again, a high yield section, I would call this. It
Yeah.
scores 5 points. You get points for things like writing a chapter in a textbook, writing a whole book, right? That also gives you point. Having a higher teaching qualification. So, for example, a diploma, certificate, or master's in medical education, that gives you points. designing an e-learning course. Doesn't matter if you did it wherever, if you did it in ophthalmology, if you did it in stroke or whichever department, designing a course yourself online, right? And online or otherwise, even in real life, if you have designed a course and completing a teaching the teachers course as well, that also gives you a point. So what I have done in this section, this is a good thing because I think it's a good example of what you can do before you actually start coming to the UK. Is when I was applying for the jobs to UK back in Jan of 2020, when I first got my GMC registration, I signed myself up to an online part-time postgraduate certificate in medical education
Yeah.
for this entire purpose, right?
Mm.
So that was a 1 year's degree from University of Glasgow,
Mm.
fully online. I was doing it from my home back in UAE, and that was aimed at getting these 3 points in the education section. They're pretty hefty points. Same thing, if you want to do it as well, just sign up to any online postgraduate certificate, 1 year long in medical education. This way, you also get to learn how to teach students
Yeah.
in the future when you actually come into training, because teaching is again a big part of our training as well. We get to
Yeah.
teach medical students a lot. This gives you those skills. It gives you those sort of understanding of how we can be better teachers.
Yeah.
And at the same time, you're getting 3 points. 3 points is the same as doing FRC of part one exam
Yeah.
for the clinical commitment section, right? So I had that. I had 3 points from there.
Mm.
I had 1 point from making an e-learning course at the stroke unit where I was working. So I created a sort of like a Microsoft Teams platform, which was accessible by everybody in my department. What we used to upload over there was the weekly teaching sessions that we used. So every weekly teaching session that used to happen was
Mm.
recorded, and I would put it there. I would label it. And it would be accessible by anybody everywhere in our department, from home, on their phones, in the hospital, and this became like a teaching platform. So
That's good.
this scored 1 point for me here, and I did the teachers course that gave me 1 point as well. So there are my 5 points. I didn't have to write a book. I didn't have to find somebody to write a chapter of the book.
Yeah.
I did the degree on my own. I made the e-learning course, and I did the teacher course, and that's it. Maxed out this section as well. Finally, the last 3 points are from the overall portfolio layout and quality. This is something I believe anybody can score well in. You just
Yeah.
have to spend a little bit of time making it a bit aesthetic, making it look a bit good. The PDF that you make. What I would suggest is making a nice content page
Yeah.
before every section. What are the things that you're mentioning in there? One, two, three, four, and then go into the evidences.
Mm.
But if anybody wants to have a look at my portfolio as well, I mean, feel free to contact me. I can happy to show that. So again, maxed out in this section as well, as should everybody. That's about it. That's the whole portfolio. So as you can see, at various points you can
Mm.
start doing these things from your university itself, especially the posters, the presentations. You can start working on these even when you're back in university. And the sooner you start, the better, because it
Mm.
can take time sometimes with the rest of the portfolio. Yeah.
I think that's a very good
Mm.
breakdown of different component. I think people can get a lot of ideas from how can they improve their own portfolio. And you're absolutely right. Some of the things you have to start early in the career, because if you leave everything at the last minute and you'll just put your 6 months on or a 12 months time limit on yourself, then you'll be very stressed that these things are not getting done. Some of the
Exactly.
things you
Yeah.
mentioned there, the presentations in international conferences. I think for IMGs, I always say to IMGs, you have an advantage because we come from a country. So we are when I'm here from Pakistan, for example. I know there are conferences happening in Pakistan. I'm talking about psychiatry. So if I have to get an international publication or an international presentation, in that sense, I can go to back to my home country and do that, and that will count as international as well, because when if I'm based here, so we can use our links back home or back with the
Exactly.
foreign countries as to get those international presentations as well. That's one of the things
Absolutely. Yeah.
I was going to mention. The other thing you mentioned about being organized, I think that's very important that we take note of some of these things. And I must say, although you were talking about ophthalmology, but a lot of these things will actually will contribute to other portfolios as well. So,
Yes.
if you're applying for IMT, for example, and other specialties, a lot of this evidence that you have done teaching, you have done audits, quality improvement activities. You have been involving yourself in research that can be used in other specialties as well. It's not just that you have to be and only using
Absolutely.
in ophthalmology.
Absolutely.
But
Yeah.
you're right about the fact that I think you're a very good example. A lot of people ask, if I have never worked in ophthalmology, can I get an ST1 job? But you're a very good example that even if you have not worked in ophthalmology, you can still show your commitment to specialty. And as you mentioned, developing that context with the local department wherever you're working. If you're working in a hospital, you will always have an ophthalmology department. If you're working in a trust where you don't have it on your site, on your hospital site, there will be another hospital somewhere nearby where the patients of ophthalmology are going. And
Yes.
if you if you go and introduce yourself to that department and the senior doctors in that department, they are usually very helpful, and they actually encourage the people who are coming from outside to spend some time
Yes.
with them and help to develop their portfolio and help to show the commitment. I think that was a very good example of how you did it. So just for specifically for that point, how did you contact your local department and how did they help you?
I was actually just going to speak about that because I feel so much of my portfolio has been contributed just on the basis of the contents that I made in the eye department. So basically, first a little bit introduction about my stroke job. My stroke job was a purely ward and on-call job. So it's a hyperacute stroke unit. We have a busy on-call rota and we have a busy ward rota. We don't do any clinics. So firstly, my whole thing was to get used to in that job for the first 6 months when I came to UK. I wasn't really thinking about ophthalmology because again, just the learning curve of the job itself was quite
Mm,
heavy. And after these 6 months, I realized, right now I'm a bit settled in my job. Why don't I go and chat with the local I unit and see? I knew the portfolio. I knew what I wanted out of this department. So that's
mm,
important. You should know what you're looking for once you go there, because once you go and talk to the consultant there, you should know what you're asking for. It'll be wrong for me to go there and say, "Can you please help me with my ophthalmology training?" without knowing what I actually want to do. So I knew that from that department, first of all, I wanted a taster week. I wanted the casualty and theater sessions. I wanted any projects that I could do in terms of research, because again, publications had quite a hefty role.
mm,
Presentations had quite a hefty role. I wanted these things out of the I department. So I went there. I introduced myself to one of the consultants there, and I said, who's I think leading the education section of that department at that time, and he advised me, all right, if you're interested, you can join us for this project. This one of my residents is doing this projects,
yeah.
and if you would like to join with him, maybe you can be of any assistance to them. I told them, look, I'm going to be here in this job locally for quite some time. So even if you're junior clinical fellow and anybody changes job, I'm still here. I can still help with this project. And so we started doing a project, which was a survey based project, about sort of eye symptoms in COVID patients. This was back in 2020 and
Mm,
2021. I would give a lot of credit to this project, because even though this was not ultimately published, because the sample size ended up being not large, I think it was 30 patients out of the 120 that we needed
yeah.
who actually replied back to our survey. Uh, I did quite a lot with this project.
Mm,
Now, just because it wasn't published doesn't mean that you can't do much.
yeah.
I took the project and I asked my consultant in the I unit, what can I do with this? They said you can present it, you can poster present it, you can sort of like speak about it in international conferences. I was like, okay. I applied to about 10 or 11 international conferences in one sitting with my abstract for that one study, unpublished, right? I got acceptance from one. That's it. And this was an international conference called EVER, which is held in a different country every year.
Mm,
It's the European sort of ophthalmologic society.
yeah.
They accepted my presentation for an oral presentation. So international oral presentation, that's 3 points guaranteed from a study which isn't published.
Mm,
But because they were interested in seeing my findings
yeah.
here in England about COVID and eye patients, they wanted to see that, and so that got accepted for me. And so then I traveled to Spain to present my study there. And the oral presentation, international, ticks both boxes for
Mm,
getting 3 points in the portfolio. And the good thing about EVER is that conference is all the oral presentations that they have in their conference, they publish them in their own journal, which is now considered as a non-peer reviewed publication in my
mm,
portfolio. So that's 4 points out of a study that only happened because I went to my department and just asked them, "Do you have any project I can get into?"
Mm.
So that's one example. Second is that my theater session, my casualty sessions, every time you attend, you're reminding yourself why you like this specialty. Every time you're sitting there, you're seeing those patients
Yeah.
outside of your work, whatever you're doing. You're reminding yourself, you're sort of reinvigorating your own passion for that specialty. And that also helped me a lot as well. So that's how, yeah.
And coming back to the training, I think you've given some very good examples about how to make the portfolio and how to score. But now
Yeah.
coming to the training, how long is the training and what are the exams you're supposed to do during those training years? I think that is something people would also like to know.
Yes, for sure. This thing has also changed actually now over time. So in 2024, they will be starting a new curriculum.
Mm.
So ophthalmology will be changing its curriculum from the previous curriculum, excuse me, to the new curriculum in 2024. The old curriculum, which has been running up till now, was 7 years long. So it's a run-through program.
Mm.
You start at ST1, you come out the other end after ST7 as a consultant, as a general ophthalmology consultant, run through without any sort of interruptions. The new curriculum is meant to be 5.5 years long. So
Okay.
it'll start at ST1, again run through, and then 5.5 years. The difference is that the in the last couple of years of the old curriculum, you were going into your specialist area of interest
Yeah.
and then coming out the other end. But in ST and the new curriculum, that focus will be less so that you can finish early and join a fellowship
Yeah.
earlier on because you're going to need fellowship regardless
Mm.
in both circumstances. There are a few more differences, but those are the nitty gritties which we can get into. That's the new curriculum. Anybody who's currently in the old curriculum, if they are in the earlier years of their training, like me, ST2s, ST3s, who are still in the last year of the old curriculum, they will be automatically transitioned into the new curriculum
Mm.
next year. But I'm sure everybody who's listening to me who's not in ophthalmology yet, for you, the new curriculum is the one which will actually be relevant. Yeah.
And the
So
exams, how many
the
exams?
exams, great. The exams. So there are a few exams. Essentially, it's FRC Opht. So if you want to become a fellow of Royal College of Ophthalmology, just like you do MRCP,
Yeah.
those are the main exams, along with a refraction certificate. So FRC Opht Part 1
Mm.
and FRC Opht Part 2. Now, these are the two exams, but the Part 2 has two further exams. So I'll explain how. FRC Opht Part 1 is basic sciences,
Mm.
only related to eyes, right? And optics, how light works, how vision works. Then part two, you have a written exam, and then the last exam, part two, is the oral exam. Part one, part two, written, part two, oral
Mm.
exam. By the end of your training, you're expected to finish all three exams. By the end of your first 2 years, you're expected to finish part one. That's it.
And the refraction certificate you have to finish within those five
I
years.
think I think refraction certificate is within the first 3 years
Yeah.
that you have to finish the refraction certificate. So for me at the moment, the most relevant exam to work on would be, if you think about the time constraint, it will be the refraction certificate.
Mm.
But it's important. It's good to study part two exam just alongside because it's a clinical exam which talks about how you deal with patients in a
Mm.
day-to-day setting. So these are the exams. Yeah.
And I think people often ask about the day-to-day job, how does
Yeah.
it, I mean, I know you're new, but still, what is your impression about ophthalmology? If you could run us through the day of what sort of things you do,
Yeah.
and also the on-call system, because a lot of people get worried
Yeah.
about on-call. Is there too many on-calls? How busy are the on-calls get and all that?
Right, right. It's a great question. Now, the on-call sort of rota varies between regions in
Mm.
the UK. Some regions will. I know in some regions the sort of ST1s don't do any on-calls for the entire year.
Mm.
They can work till late. For example, they might be expected to work till 11 p.m. or 10 p.m. in the eye casualty,
Yeah.
but then they can go home and the second on-call is actually the registrar, senior registrar, who's overnight on call by phone. But some regions, like my region, we do have on calls even for ST1. So I'll take you through my rota. So The day-to-day job, first of all, in the week, you're supposed to have clinics and you're supposed to have theaters, right? The clinics are of different variety. There's the casualty clinics, acute referral clinics, as they call in our east of Scotland region, where anything that walks through the door, any emergency that can come. So you can have retinal detachments, you can have trauma, you can have children with orbital cellulitis, any sort of ocular emergency can just walk through the door,
mm,
and that'll be casualty sessions, right? So you could have maybe 2 or 3 sessions. When I say sessions, it could mean AM and PM. So AM is a
yeah,
session, PM is a session, right? So you could have maybe 2 to 3 acute referral clinics sessions in a week. You're not running them alone. That's an important thing to understand. As an ST1, you will always have somebody else in the clinic, more senior, who you will be working with. So you're discussing your patients with them if you're unsure. You're even getting them to see your patients as well if they're concerned that this might need some senior input. You are
mm,
not alone. That's an important thing to understand in these urgent clinics. So that's there. Next thing is general clinics, where you will be seeing not so acute patients, but they have mostly general problems, not requiring any specific specialty input. So many times dry eyes, which are like not getting treated, and you're just trying to add more and more treatment. Uveitis, some inflammations going on in the inside of the eye, which does not need a specific subspecialist input anymore. General clinics, so you get like general stuff. Again, even in the general clinics, you have a consultant supervising,
mm,
so they're running their own lane, you're running your own lane. If you have any questions, you can just go to them and you can ask them about management plan or whatever that you might. Maybe a couple sessions of general clinics, couple sessions of theaters. So you will
mm,
be in theater with your senior, with your consultant, and every consultant has have their own way of teaching you.
mm,
So some consultants prefer to what, and also what are we teaching? We're teaching cataract surgery from the get-go.
mm,
When you're in subspecialist firms, in subspecialist rotations, you will also be taught other stuff. So maybe ocular plastics stuff where you're
mm,
doing plastic surgery around the eye. It will have its own learning time. But in general, you are required to be very competent at cataract surgery by the end of your training, right? I think by the end of 2 years, ST2, you're supposed to do 50 cases independently. That's a requirement that you have to cross before your second year of training.
yeah,
50 cases independent cataracts done by yourself. You get there slowly at the beginning. Some consultants like to teach you from the back to front, so the
yeah,
last step first and then second to last. Some like to start from the beginning. It's just a personal preference. My trainer has advised they would like to start from the back to front. So that's what I'll be following as well. 2 theater sessions a week, 2 or more. Sometimes you can have one, sometimes you can have two, depending on staffing levels.
mm,
But in general, that's the overarching thing. Then you also get some research, study, teaching, audit time, which we call RSTA time, right? That's what we call here in east of Scotland. Maybe in other regions it's called something different. But these are essentially unbooked slots. It could be a
mm,
PM which is unbooked. It could be an AM which is unbooked, which is expected of you to spend time on research, on audit, on teaching medical students, or your own self-study. And at the end of the year, you will also be asked what you did in these RSTA times, right? And so you have to have some sort of project going on the side, which you work in this free time. I think, well, that's a very good thing, because in non-training jobs we don't usually get
mm,
such dedicated times. We just have to figure out time by ourselves to work on these things. But in training, you get these sort of allotted times
mm,
to work on these things. So that's also maybe two or so, 2 or 1 sort of sessions in the week of that.
yeah,
One session compulsory postgraduate teaching session.
yeah,
For us, it's on a Friday afternoon, where the teaching is given by our seniors. Could be from our seniors, could be some external speaker who comes over to our department and speaks. It could be one of our doctors as well who's giving teaching as well. So that's postgraduate teaching. Apart from that, yes, the specialized clinics as well. So in east of Scotland, we have 6 monthly rotations.
yeah,
So I am currently on the diabetic and vitreoretinal firm, which means for the 6 months, I will be running the diabetic clinic along with my diabetic team members.
yeah,
This is separate from the general clinics. So that I'll probably do like 2 or so clinics a week, sessions a week of dedicated diabetes. In pediatrics, you will be running pediatric clinics. In
yeah,
oculoplastics, you will be running oculoplastic clinics. So that subspecialty
yeah,
clinic is also present. This is the weekly non-on-call situation, right? Then you come to on-calls. On-calls are very dependent, again, as it depends on how your region does it, but I'll explain how it's done in my region. In my region, we have first on-call, second on-call, and the consultant. Now, on the weekend and on the Friday, the first on call is always one of the juniors, so ST1s or
Yeah.
ST2s. We are the first on call. The second on call on the weekends and Fridays is one of our senior registrars. So maybe an ST6, 7, 5, 4. They
Yeah.
will be our second on call. And the consultant is on the third. That is the weekend and the Fridays. On the weekdays, though, there is no senior registrar in the middle. It
Yeah.
is us being the first on call,
Yeah.
ST1s or ST2s, and the consultant on the phone at home. Right?
Mm.
So what the way the on-calls work is, firstly, all on-call is non-resident, so which means that you don't have to be in the hospital to actually be on call. You're on call from your home
Yeah.
on your phone. You just have to decide what is an emergency that you need to come in to see
Yeah.
overnight, right? So it's overnight on call. After it starts after 5 p.m. though, till 5 p.m. If you remember, we spoke about casualty clinics. That is the
Yeah.
on call.
Mm.
Those are the people who are holding the bleep, and they take care of the on call from the morning 9 a.m. to like 5 p.m. There's nobody who's dedicated on call. Right? After 5 p.m., whoever is first on call sees if there are patients in the casualty who need to be seen. So everybody else goes home. The on call sees if there are still patients to be seen in the casualty coming with whatever emergency, red eye, painful eye. They sit there for a while. Maybe they can sit till 9 p.m., 10 p.m. They hold the bleep as well. Uh, Once they feel that the clinic has calmed down, they can then go home. And once they go home, they're on the phone.
Mm.
And on the phone, they can be referred any patients from emergency department, any patients from out of hours, and those can come directly to you. That's how generally the on call works. Yeah.
Okay. Well, thank you for giving us a very good idea about how things work in ophthalmology. Is there any advice you have for the junior IMGs who are thinking about the specialty, or, as you said, who have done a few years of training or work in their own home countries, of how to go about and what to do?
Yeah, correct. So that's a great question. The I think the best thing to do is, yeah, I think this was a point worth reiterating for me, is my best resource for guidance has always been actual trainees, the actual
Yeah.
trainees who have actually gotten into training recently, right? Online, you will only find things to a certain extent, but there is so much more, especially in terms
Yeah.
of how to build your portfolio, how to prepare for the interview, which you can only know from people who have actually gone through the process. And I think for me, one of the biggest, you can say hurdles or obstacles, but was that I didn't know of any IMGs who had actually gotten
Yeah.
into ophthalmology. And so, but that was fine because I had some very, very sincere and very kind senior trainees that I got in touch with who were most happy to help me regardless in this situation. Um, the only thing I had to figure out was how could I get the things that many other ophthalmology candidates have gotten in their undergraduate years here in the UK.
Yeah.
How do I make up for that for myself, because I had no background in that. So
Mm.
get in touch with all the trainees. Look, I'm here for support.
Mm.
I would like to leave contact links here for myself as
Yeah.
well. So if you need anything, contact me on my Instagram. Let me know if you want any videos made on certain topics, or you just want to speak with me about interview guidance, portfolio guidance, MSRA guidance. Speak with me. If you have any local trainees that you know of, speak with them and make them your mentor. Make them your mentor and ask them to help you through the whole process.
Mm.
That will be your gold mine actually to
Mm.
get into training. You cannot find everything online. You cannot find
Okay.
everything from even consultants. Consultants might have done their training quite a few years ago,
Mm.
but especially in ophthalmology, because things change quite a lot,
Yeah.
especially in terms of training. It's the most recent STs that actually helped me the most in my training. And an important thing to remember is one of if, the whole reason I came to the UK was because I wanted to get into ophthalmology.
Mm.
Because I knew that in the UK, at least you can work towards it. It's not the sort of circumstance where you have to sit outside in your country and do the exams, and if you're not competitive enough from your own country, you cannot get into a
mm,
specialty. Just how, for example, the American system sometimes causes that sort of a situation. Here, at least, you can get to the same playing field as
yeah,
everybody else, as long as you have the merit. So
mm,
the portfolio guidance is there, the numbers are there, the points are there. You just have to take them.
mm,
It took me about 2.5 years. So the first year of my attempt, I was let down by the MSRA because I underestimated the MSRA. I
yeah,
thought, oh, it's just an easy exam. And so the next year, I was much more serious about the MSRA. I was much more serious about the interview. And that's when things worked out for me. So
mm,
another thing, don't expect things to work out the first time around. This is not that kind of a specialty where you can think of, oh, if I try one hard time, it's going to work out. There
mm,
is a high likelihood, as is for most candidates, second attempt or thereafter,
mm.
you might actually get in. But very doable, very doable, right? It's you just have to follow the criteria. That's it. Nothing apart from that. I didn't have any publications. I didn't have any prizes. I didn't have any sort of degrees outside of my main medicine. And yet I am also in training right now. So
Mm.
can you. So can anybody else who doesn't have any publications or um, uh, year-long degrees, PhDs.
Mm.
Very much possible. You just need to be dedicated towards that specialty. That's it.
So thank you for all your advice and guidance. I think it was very useful. And I would like to say Dr. Saad has a very active Instagram page as well. So I will leave the links for that and the links to how to contact him. So if there are IMGs who are specifically asking for ophthalmology, you can get in touch with him and get some specific guidance. I also like to say that his point was very relevant when he said that the best people to guide you are the people who have done it recently, because people who have done it in the past, sometimes we just certainly run to a consultant thinking that this consultant might be the best resource because they're working in that especially for 10 years, 15 years. But they have the recruitment when it was done for them, it was completely different. They might not have kept in touch with how things have changed. So it's either the person who has recently done it or a consultant who is actively involved in the recruitment process itself are
Exactly.
the best people. Otherwise, you may end up getting misguided. But then also another advice I give to people, which Saad has already said in his thing as well. When you're approaching a department or approaching a senior, you need to also have done some of your research as well. You can't go to them and say that,
Yes.
I am interested in ophthalmology, help me out and tell me what to do.
Yeah.
If you already have things in your mind, like Saad has already mentioned that he wanted to do an observership week in the department, and he wanted to get some things signed off. So if you go to them with specific goals in your mind, then they will be more likely to actually hold your hand
Absolutely.
and take you forward. Because if you go to them with complete blank, then people might be put off by the fact that you haven't done your research. That's just
Yeah.
something
Yeah.
I thought it's worth mentioning. But
Absolutely.
thank you
Absolutely.
very much, Saad, and for doing this. I think this will help a lot of IMGs, and this is one of the specialties, as you said. There's a lot of guidance out there for other specialties like psychiatry, peds, IMTs, even core surgical training. But the ophthalmology is one of those when people are just, even by the name of it, although they like the idea of becoming ophthalmologist, but just thinking that is the competition is too tough, they will just back off. And seeing you as a role model, I think will give that energy to a lot of IMGs that they can actually do it as well. So thank you again.
No, no, thank you, Dr. Raja. I just also want to mention that you have always been a big role model for me because I've always seen your interviews as well and your guidance on just coming to the UK and settling into the first few jobs. I think your content has really helped me a lot. So thank you so much for that.
Thank you very much. Thanks.